Hi, everybody. Nice to be here with everyone. Glad that you can join us. This year, we've got a great Grand Rounds lineup, and we're happy to kick it off this year with Dr. Tyra Fainstad. I think you're all aware, too, that we're having a hybrid approach this year, so those who'd like to attend in person are welcome to do so. Pay attention to the precise location because we've got two venues that will be switching between this year. And then, of course, if you'd prefer to attend via Zoom, we'll have that available to you as well. So without further ado, Dr. Tyra Fainstad, Associate Professor of Medicine in the Division of General Internal Medicine. She went to college at UC Santa Cruz and med school here at CU, residency at University of Washington, where she also did a chief year. Dr. Fainstad is our residency director at Lowry. She's an outstanding clinician. She is an outstanding researcher, and her interests have focused on creating safe learning spaces, as well as optimizing the delivery and the reception of feedback. She's also a professional life coach, and she has particular expertise in the imposter syndrome. And so Dr. Fainstad is going to be speaking with us today about how the imposter syndrome is relevant to us and our learners. And very grateful to have you here. So Tyra, the stage is yours.
Thank you. Hi, everyone. I am Tyra Fainstad. And yes, I am a doctor and a teacher and also a life coach, which is kind of nuts and super different than I think most of the Grand Round speakers that you have. But I'm really excited because I think there's a huge overlap actually in burnout and the sort of surge that we're seeing of physician generalized poor wellness and also burnout and imposter syndrome and imposter phenomenon. It's actually something that I got into learning about much before the pandemic, but I think has been precipitated by the pandemic for a number of reasons that I'll share with you. So imposter phenomenon, I'm going to present it to you in this way. We're going to spend some time defining it. I'm actually going to spend a little bit of extra time here because I think the definition can be nuanced and it's important that we have a shared one. And then I'm going to identify the cause, and this, even more so than the definition, I think is tricky. And I want to be sure that I tell you about the cause in the right way and how I'm approaching it. So we'll spend a little bit of time there. We'll briefly understand the effects of it. And then I'm going to spend the bulk of this time teaching 3 tools to mitigate its effects in your learners and, parentheses, also in yourself, because I think all of us trained and basically were raised in a medical system that kind of on purpose precipitates imposter phenomenon. It serves the institution pretty well. It might have served us well in the beginning, but my hypothesis is that it no longer serves us and in fact is probably sabotaging us. So I'm going to spend the bulk of this time on a skill, kind of life coaching 101, which is the reframe, and then we'll talk briefly about the last 2 skills. Okay, so we're kicking off Grand Rounds, and I'm going to ask you to do something really unusual. I want you to pull out a piece of paper or your phones, if you can, and think about a time that you felt like you didn't belong where you were for whatever reason in the last month. It could be in medicine or outside of medicine, at home, in the world, professionally or not. Take a minute and jot down a few thoughts about that situation. Yeah, it says ceiling mic. Oh, can you all hear me now? on Zoom? Better?
It's like, okay, we can be ready. So
You're good? Should I repeat, summarize what I just said?
possibly.
Okay. Everyone, we're going to talk about imposter syndrome. Sorry about the audio issues. It's pretty clear from the slides. Jot down for a moment just an instance where you feel like you didn't belong somewhere in the last month. And I'm going to make everyone who showed up in person do something really uncomfortable and turn to their neighbor and share a one-liner of that situation. If you are on Zoom, you get to hide behind your computer and throw it in the chat.
So I think
It's probably for next year, on the resignation, what I have to do, like.
I'm also scared of conversation sure. And then one more conversation about this and I'm dying the next day. So like he's clearly having some challenges around this.
We all have different dreams. The dream for me is college. I think there's
Yeah,
about to have
yeah,
an exam.
Hey, I'm hoping to lure everybody who's at home into future grand rounds by showing you all how exciting it can be if you come in. Imagine if you got to actually hear your colleagues share their stories. Although I'm hoping that some people
Parts of it.
What I want to show you is that actually feeling like an imposter in certain situations is really normal. It's pretty common. The definition that I will share with you today is this one. It's really simple. It's a collection of thoughts and feelings around inadequacy. And the key to imposter phenomenon is that these feelings persist despite evidence to the contrary. So this is really key because it separates imposter syndrome from healthy uncertainty. And that's a question I get asked all the time. I am a coach for residents and medical students and some faculty also. But the question, shouldn't I feel like an imposter sometimes? I'm learning to be a doctor. Isn't it totally normal to not feel like I belong here? And the answer is yes, of course. We want healthy uncertainty. We want you to know the boundaries of your limitations, and we definitely want you to feel uncertain. It's this corollary. These feelings of inadequacy persist despite evidence to the contrary is when it becomes a problem. So for instance, if I felt a healthy level of uncertainty before preparing a grand rounds talk, which is something that I don't do all that often and still gives me a pretty healthy buzz of adrenaline beforehand, that actually kind of serves me. I feel nervous before getting up here in front of you all, the group that I care a lot, how you think and perceive of me. That will probably drive me to do things like practice, go over my slides extra, ask for feedback, and perfect it until I felt like I was ready to give you this talk. I don't have a whole lot of evidence yet that I'm a great grand round presenter, and so that level of uncertainty is actually serving me. Now, if I felt those same feelings of inadequacy before like an annual Medicare wellness visit, that would probably not serve me. Because if I had those same thoughts, what if I don't know what I'm doing? I might mess this up. It would drive me to ask for feedback from colleagues and get on up to date for every single question that I had and take forever to write my notes. That would really hold me back. So those are two really extreme examples, and many of us fall somewhere in the middle, but I just want to take the time to differentiate it from healthy uncertainty. I also want to call out, when we talk about syndromes, usually the person that has the syndrome has the thing. So if you have irritable bowel syndrome, you have an irritable bowel. If you have imposter syndrome, you are not an imposter. It's just that's, for whatever reason, the tagline. I think it really should be named self-underappreciation syndrome, but no one's changing it Okay. Here is how it shows up. These are really common phrases, especially that I hear as a medical educator. The one that I hear over and over again is in response actually to positive feedback or praise. Medical students or residents will commonly brush this off as just being nice.
So sorry, whatever button you pressed before, can you make that go away? Sounds like that.
Okay, made it go away. Day one of new season of Grand Rounds. We're figuring it out. Okay. Yeah, excellent. They're just being nice is a way of praise deflection that I hear over and over again. And it's something that gets internalized. We're going to come back to why specifically this happens. But also, you know, I just lucked out. I had a lot of help. Any reason that they can make it so that whatever strength they are being praised on is not their own, but because of someone else, is usually a telltale sign of imposter syndrome. The prevalence is high. Most doctors will report feeling some level of imposter syndrome at some point in their careers. 2/3 of trainees report sort of living in imposter syndrome most of the time. And it's much more common, about a 2-to-1 ratio in women, and way more common in those that are underrepresented in medicine. Which leads me to ask, like, really, why is this? Whose fault is this anyway, is what that data has precipitated. If you haven't read this really easy to read one-pager Harvard Business Review article from last year, I highly recommend it because it calls to the forefront basically the cultural issues that have precipitated imposter phenomenon in those that are underrepresented. It's called Stop Telling Women They Have Imposter Syndrome, hashtag or parentheses, when you aren't fixing the environment that led to the imposter syndrome in the first place, right? And so maybe we feel like we don't belong, or that we're a fraud, or that we're not supposed to be here because there's a silent one-liner coming from the institution that says you don't belong, you should change how you are, you're not supposed to be here yet, is what this calls attention to. This is so useful to know. It's very useful to know, especially in the people that I am coaching. When it starts to become unuseful is when it becomes a blame game, right? Anytime we bring up an issue about fault or blame, what I see happen is a battle over whose job it is to address, right? Then the armor comes on and it becomes a little bit scary. In medical education and in medicine in general, this is how I see it play out. On one side, you have the institution or the program or the system or the hospital who's kind of saying like, yeah, okay, we have a wellness problem, we have an imposter syndrome problem, we have a burnout problem. I think maybe we need to help our doctors with resilience. Let's give some resilience workshops. Maybe we'll give some mental health resources. Here's some free coffee. Do you feel better now? To which the doctors respond, are you effing kidding me? Give me a better EMR. Lower your productivity requirements. Like, this is an unworkable system. Are you blind to all of this? And then there's a big fight that happens, right? Both sides obviously are working towards the same goal, but they're missing most of the iceberg, which is the culture of medicine that we are all contributing to and all making up through no fault of anybody's, which I think I will lay out in a bit. But there's a pretty toxic culture in medicine that rests on ideals like perfectionism, a bit of martyrdom, right? It idolizes overworking, overcommitment. And it's a place that we've all trained in and created together. And so until we address really the culture that has created this battle, I don't think we're moving anywhere. There are two sides of the culture program. There is the societal or programmatic or institutional side, and then there is the individual who's affected by it and contributing to it. I want to say explicitly, I realize that many of the thought patterns that individuals have are because of the problems in the culture that we are working in. However, I think if we ignore the power that we have as individuals to look at our own brains and look at our own power and wait for the institution or society to change, we will be waiting a really long time. In my opinion, that's what's wrong with sort of putting all the blame on society or the institution and staying in a victim mentality and waiting for it to change before you can feel better. I think there's actually a lot of power in working for yourself and together to change the institution. So both need to happen. As a coach, I'm very focused on the individual, and so that's what I'm going to talk about today. Okay, zeroing in on imposter syndrome. What is the cause? The cause of those feelings that persist despite evidence to the contrary is an overactive inner critic. This is a picture of my inner critic. She's really mean. The inner critic is a negative self-talk voice that actually lives in the lower brain. It is present in all humans. It's been studied in many domains of cognitive science, and it will light up on an fMRI when you are saying mean things to yourself. It's in the amygdala, and it probably has a cause. So it probably is there to protect one from being kicked out of the tribe or society. It was probably actually hugely evolutionarily advantageous when we needed to know if we were acting kind of funky and at risk of being ostracized, which meant sure death at one point. The inner critic is something that learns from data points and is definitely fueled and informed by society and the messages that we're fed all the time. So it matters as women and as those that are underrepresented in medicine, when we hear messages that we don't belong, those fuel our own negative self-talk center, right? Typical inner critic voice, this is mine. She lingers on the negative, very micromanagey, has something to say about everything I do, adds to the cognitive load a lot because I'm always managing her at the same time that I'm also trying to do the thing, like take care of the patient. And like I told you, the inner critic lives in the lower brain. It lives in the amygdala. And so in that center, it easily goes into fight, flight, or freeze. That is its normal automatic response when it feels a threat, right? Has a term, it's called the amygdala hijack, and it comes up when there's any question about social safety. Am I at risk of being humiliated, ashamed, kicked out of my tribe, perhaps, right? Am I safe? If not, choose one of these actions is sort of what happens there. It's in that fast pathway of the lower brain. If any of you have read Thinking Fast and Slow, this pathway lives almost subconsciously unless we then look at our own brains by self-coaching or having a coach help you look at your thoughts. So it happens usually without you even noticing. The effects of going into fight, flight, or freeze regularly in your career look like this. And this is what I see in the residents that I coach. These are the outcomes that I'm trying to mitigate in coaching for imposter syndrome. The most common one I see is declining opportunities and challenges, because if you have a thought that you don't deserve to be here, or maybe someone's going to find you out, taking a challenge or an opportunity that you don't quite feel prepared for is the last thing that you're about to do. Okay, every time I talk to trainees about this, the very first and most important thing I do is normalize it, right? So everybody's brain evolved with a negativity bias, which is very, very useful for survival. Being very vigilant probably served us a lot and maybe served us today, right? Also, these mediated responses are automatic. You can't change them necessarily, even if you want to, unless you notice them. Unfortunately, now in the 21st century, when being kicked out of your friend group does not equal death, this over-amplified inner critic is not helping us very much. The second layer is that I think medical training actually on purpose amplifies the inner critic. First, necessarily, the way that we're taught to think and the way that serves our patients the best is actually to have a really strong negativity bias. We are constantly asking ourselves, what is the worst thing that could happen here, right? What is the thing that is going to kill my patients for sure? What is the thing that is going to lead to the worst outcome? So we're like just walking around catastrophizing on purpose all day. And so it feels very normal then to continue to do that in other aspects of our lives. In fact, we may not even notice it. But if that's the norm, when we train for 80 hours a week, doing that at home in other areas is going to feel very automatic also. Secondly, something that I've noticed after years of coaching medical trainees is this collective belief of turning the inner critic on ourselves and thinking, if I'm hard on myself, or if I don't trust myself, or if I keep telling myself that I'm not good enough, that will actually make me be a better doctor. I'm not sure exactly how this gets started. I have a feeling it's multifactorial. It comes from a pretty toxic hierarchy that's still in place and raging today, and also just having to create a negativity bias for our patient care, then to reflect it on yourself and say, unless I feel like I'm doing bad, I might be unsafe, right? If I am too cocky or overly confident, or even if I feel just okay, I might be missing something. So there's this collective belief of I need to feel bad in order to do well that is just fueled as the years go on in medical training until it feels normal. If I feel like I'm enough, if I feel like I might be awesome at this, I'm going to miss something, right? And so that's what I want to challenge. So how do we treat it? First, I want to say that we are not getting rid of the inner critic, right? People with an overactive inner critic are not broken. Nothing's gone wrong. In fact, we couldn't get rid of the inner critic if we want to. Like I told you, it's in this very specific spot in the amygdala. So you'd have to have like a really, really specific stroke or brain injury in order to get rid of the inner critic. Sometimes I think about this and I wonder what that would look like. And probably you wouldn't want to be that person anyways. So we're not trying to get rid of the inner critic. It's like we're just trying to give that inner critic some glasses to start seeing things a little more objectively. So we're going to do that by looking at the thoughts that the inner critic offers to you and then reframing them. The first step, of course, is to bring awareness to it. Here is a tool that I use in the coaching program to bring awareness to your thoughts. This is something that I learned in my life coach certification. My partner in coaching, Adrienne Mann, calls this the SOAP note for the brain. So this is how to look at your thoughts or think about your thoughts. Another term for that is metacognition, thinking about your thinking. And this is a tool that doctors tend to like because it's a framework and we just love frameworks, and it is also pretty evidence-based. So I learned CBT in medical school in like my half day of therapy or whatever it was. I still remember sitting in the classroom and learning CBT and DBT and all of that, and they went over this. And so I for sure heard this, but I didn't internalize it. So I want to pose to you to be open to having your mind blown by this, because when I did internalize it, it literally changed everything for me. So take a second and hear what I'm about to tell you. Everything in your life, every single thing, falls into one of 5 categories. Only one of them is outside of your mind, and that is the circumstance. Circumstances are things that happen outside of you. They are the data points that come into your brain, and they are neutral and factual and 100% true. You could prove them in a court of law. So a circumstance about today is that the high temperature is going to be over 90 degrees. We could prove that in a court of law. Everybody sort of believes it to be true. Circumstances are what trigger our thoughts. So our brains make meaning out of all the data points in the world, and they do them through thoughts. That's what a thought is. So I have a thought about that that's like, yay, extra summer. I love summer. I think it's great. I don't have to wear a jacket. My kids are still in the pool. It's really fun for me. I'm a summer person. My mother-in-law, I just saw her. She takes my kids to school, and she came in just full rage about the weather. She did not share my thought. Same circumstance. She feels like the world is ending this year. To her, this is clear proof that doomsday is coming. Also, she needs a new air conditioner and the end is near. And that shades her entire day, right? So she's making her experience, her brain is offering her a thought about the same circumstance that is completely different than mine. And here's the mind blow moment, my friends. It is our thoughts, not the circumstances, that cause your feelings. Right? This is crazy. And this is where I see most people, this is where I spend most of the time coaching, because most of us walk around thinking that our feelings are caused by the circumstance. And if that's true, you have to change the circumstance to feel better. So a lot of us try to change the circumstance to feel better, or wait for the circumstance to change, or just rage against the circumstance. and miss this line of empowerment, which is our own thoughts, right? It is our feelings that fuel everything we do and don't do. It's absolutely created by our feelings, and our actions, a summary of our actions and inactions is what creates a result for us in our life. Right? So I'm creating my own day with my thought, yay, extra summer. I feel like I'm stealing a little bit of extra time. I might have like a little rose-colored glasses, honestly, when I'm walking to my car. I'm creating that experience for myself with my thought. I didn't necessarily choose that thought, but I could, right? And my mother-in-law is not necessarily choosing her thought. She thinks it's just the truth. But if you look at it this way, there is some power in that thought line. Once you see it as your thoughts and not the circumstances that cause your results. In imposter syndrome, it is the inner critic that is offering you your thought for whatever experience, and the feelings are not good every time the inner critic comes. So I want you to take a peek at that reflection that I had you do earlier, or just bring it to mind. And I want you to play along. I'm going to give you an example of how to take a thought download or a free write journal entry and plug it into the CTFAR framework, the SOAP note for the brain that I've just given you. Okay, so pull out yours if you want. You can do this on your phone, or you can do this, I recommend pen and paper in the beginning, and you can walk along with your own thought download as I go through this example. This example is from a resident who is in my Better Together physician coaching program. Part of the program is an online forum where they can ask for anonymous coaching on a secure members only website. And then we write back coaching for them on whatever they bring and for others to read. It's totally anonymous. Even so, this resident has now long graduated from our program and has given me permission to use this. So here's what she brought. She posted this to my forum. I was in the NICU and my patient needed an art line. The fellow asked if I wanted to do it, but I botched the last three I tried, and I was scared to hurt the patient or look incompetent. I made up an excuse and handed it off. Maybe I'm just not a procedure person and I should consider non-procedural specialties, which sucks since I actually really like the unit and I could picture myself as a cardiologist too. But it's not worth it if I can't even place one tiny line. Okay, does anybody here know what the circumstance in this thought download is? What's the neutral circumstance here? Yes. Does anything else seem circumstantial? Isn't that so interesting? So what she said is that she failed 3 procedures before, which is what I thought also when she wrote this to me. But as a life coach, I know one key nugget, also as a medical educator, I know one really important fact, which is never to believe your learners when they bring you a story about themselves. So I actually invited this person to come up and be coached live on our next call. We hold coaching calls at night on a group format. And I invited her to come up and be coached live. And so I asked her about it. And I asked her specifically to explain what she meant by botched the last 3. And she told me the first one, she couldn't get the line and the fellow had to come in and basically guide her hand to place the line, and it took forever and she felt like it was botched. That's what happened the first time. The second time, she preemptively asked the fellow to scrub in with her because she felt like she was now struggling with art lines. The fellow came, was scrubbed in, but she placed the line. Y'all, the third one, she did the same thing, but the fellow stood in the corner and didn't do anything, and she placed the line. In her mind, this is botching the last 3 lines because she had to ask for help, right? So never believe your learner. And it turns out that most of what people bring you is their thoughts. So that's the rest of the story is all thoughts. And this is what our brain does. And her inner critic is like, oh, you had to ask for help. That probably means you botched it. You are not safe. You shouldn't be a procedure person. That's her inner critic. And this is classic inner critic coming out. Those thoughts are scary, right? They, of course, create a feeling of scared or fear in her. And anytime we're scared, the 2 most common actions or reactions that I see in medical learners are either to fight, which comes up as looking defensive, or probably more commonly is to hide, right? Freeze. So her actions from this feeling are very naturally to hand it off, not do it. If you feel scared, especially when you might hurt a patient, this is very normal. The result, of course, is that she doesn't learn this, right? We can see this. She's also labeling herself and limiting her options. So here's what it looks like if you plug it into this SOAP note for your brain. Her circumstance is the patient needs an art line. Her thought is, I failed before, so I can't do it, right? That's a summary of what her inner critic is giving her. She feels scared, of course, as any human being would with that thought. She avoids it, hands it off. She calls herself names, reconsiders career options, and limits herself, right? She catastrophizes it into a whole future of, I'm not a procedure person because I had to ask for help. And she doesn't learn how to do it. So as a medical educator, I see this and I'm like, oh, like that's a really fixed mindset. I've got to open her up to a growth orientation. How can I do it? I want her to know that she can do it, right? But as a coach, I know I can't take her from I failed before, so I can't do it, to I'm amazing at this, I'm going to do it, right? It's not going to happen. So this reframe as a life coach is not, I want to be clear, it is not toxic positivity, and it is not offering positive affirmations. What I know is that if you try to think something that you don't fully believe, your brain actually doubles down on the first thought, right? So we have to do it in a way that you are fully on board with, the resident fully buys into. So when we're attempting to reframe a thought, we leave the circumstance the same. So the patient still needs an art line, and surely she's going to run into more patients that need an art line if she decides to become a cardiologist or a pulmonologist. And when you are reframing a model, this is a thought model, CTFAR, you can actually start anywhere on any of those lines. You can ask yourself, you know, the next time a patient needs an art line, how do I want to feel? Or what do I want to do? Or what do I want the result to be? Or how do I want to think about it? In this case, we started with the feeling that if the next time this comes up, how would you like to feel if you could feel anything? She was like, well, capable. I want to feel like I can do it, but I don't. Okay, pretend that you do. In an imaginary land where you feel capable, what do you think your actions would be for the next art line if you felt like you could do it? So, well, obviously I would say yes when asked. Identify skill gaps. Maybe I'd allow failure without judging myself, and I would just sort of rinse and repeat until I got it. As a medical educator, I'm like, yes, this is what we want our learners to do, right? Like, advertise the skill gap, advertise the deficiency to all of us teachers so that we can help with extra practice and supervised procedures. This is surely going to lead to a result of her learning how to do it. We know this as educators. But as trainees and as people, we also know that this is really scary if you're walking around with the thought, I failed before, so I can't do it. There's a problem there. She's never going to do that. So we have to work on that thought. And this is the real trick to coaching yourself or someone else, is finding a thought that is believable in the moment that leads to a feeling that you are trying to create. So this takes some questioning, some non-judgmental, open, curious questioning of the first thought. And my first question to her was, okay, there's maybe some thought errors going on. If you failed before, are you sure that means you can't do it? Is there anything that you failed at before that now you can do? Probably. The obvious answer is yes. The second question is do you have some belief that you're not supposed to fail, or you're not supposed to ask for help in residency? And this is a really commonly held belief by trainees. They commonly, like the most common thing that I coach on is either them giving presentations to attendings and the attending has something to add. They see that as a failure. I can't tell you the amount of times that I have coached on an attending attestation. The attending attestation at the bottom of their note, if the attending adds their own one-liner, they're a failure. That's what they make that mean. Some of them, if the attending has like a template that is thrown in there, make it mean that that means they're a failure, because maybe the attending didn't even want to read their note. They were so bored by it. You can't win as an attending unless you're fully in the shoes of the resident learner and sort of know what they need, which is what I'm hoping to give you now. But questioning this belief of I failed before and I shouldn't fail in residency is really key, because if I drilled her down on it and I said, okay, if you believed that you should automatically be an expert, if you believed that you should do everything perfect and at the level of an attending, wouldn't you be infuriated that you had to even be a resident? Like, wouldn't it be absolutely maddening that you're making like a tenth of the salary that you're going to be making and having to answer to all these attendings if you're already doing everything perfectly? Or could it be that failure is totally a part of it and we expect you to not get it right the first time? So from that place, we came up with a couple of thoughts that she believed now. She truly did believe that asking for help is a part of training. That just wasn't the loudest voice in her head around the scenario, because it was severely outweighed by her very loud inner critic. So finding a thought that she also believes and then practicing that thought on purpose is the whole trick. Okay, that is the first tool, and that is the one that I wanted to spend the most time on. Does anyone have any questions before I move on to the second tool? Anyone looking at the chat? Yeah.
It seems critical to really identify what makes up the soul. Right? I mean, you don't do that from the right circumstance. It's kind of hard to work through.
It's impossible. And most of us walk around thinking that our circumstances are, or our thoughts are truth. That's the first step. And so the first offering that I give to anybody is, and people cringe at this, and I cringe at this too, but I can't tell you how life-changing it was. Literally just take 2 minutes sometime during your day and write down your thoughts on a piece of paper so that you can see them. Because otherwise you just walk around with them buzzing in the back of your mind thinking that they're true. So this act of writing them down, and then the second step is see if you can pull out the facts from the story. Yeah. Was that, sorry, I interrupted your question. That was it, okay, yeah. Yes. Especially in the way we talk about it, right? Because oftentimes people will be like, well, I feel like I'm just not supposed to be here. That's actually a thought. I'm just not supposed to be here is a thought. A feeling is a one-word sensation in your body. It's an emotion. And so for these purposes, the place to start is with one thought, one sentence, and asking yourself, when I think this thought, what is the most predominant emotion that comes up? And it's tricky. None of us talk or think or analyze or pay any attention to feelings. So emotional agility, or the skill of naming and processing an emotion, is what was a game changer and eventually pulled me out of my own personal burnout. But it's a skill that is not taught to doctors. We don't know how to name or process an emotion because we're not taught to. So even just this act of asking yourself, how do I feel in my body? And a feeling comes from a thought. So in particular, an emotion here, or a feeling, the way that I use it here, is not a sensation. So when I stub my toe, I feel pain, but that's actually a circumstance. That's a sensation that comes from the outside and goes up to my brain. A feeling comes from the brain and goes down into your body. And every emotion, this is also true in cognitive science, emotions live in our bodies. You experience them as a sensation in your body. So getting familiar with what anger feels like in your body, where is it? I tell my residents to do like a little mini HPI for their emotions so that they can get familiar with them. Where does anger live? Is it in your chest? Is it in your stomach? Is it in your head? Is it hot or cold? Does it radiate? Do like a PQRST. Otherwise, you won't notice it. And oftentimes, unless you do this work, the feeling feels way bigger than it is, and it feels like something you need to avoid rather than something you can totally just feel and move on. Okay. But yes, a thought is a sentence. A feeling is a one-word emotion. Other questions? Okay, the second two tools I'm going to run through much faster, no worries. Tool number 2 is managing perfectionism. Perfectionism is what drives our inner critic. And this goes along with that belief I have to feel bad in order to do well. Our inner critic sets a bar for success at perfect, right? The inner critic thinks that if you show up as perfect, you don't have to experience negative emotions. If only you can show up as perfect, you don't have to experience shame, humiliation, doubt, grief, sadness, because you've done it all right. Unfortunately, this is not true. As human beings, we all have to experience all those emotions because it's how our brains are programmed. You can't do anything to avoid feeling uncomfortable emotions, even being perfect. You also can't be perfect. So perfectionism comes up a lot in medical trainees, right? How many times have you done an interview where the person's default is, well, I'm a little bit of a perfectionist, and so that holds me back, but they know really that that's something that makes them shine even more, or they think really that that's something that makes them shine even more. Perfectionism, though, at its core, leads to unhealthy and probably self-sabotaging results. This is a key that I tell medical educators. How do you know if a learner is a perfectionist or if they have just a healthy goal that they're striving for, right? And actually, you can't tell unless you do this work. Perfectionism is generally the idea that I'm only worthy if I get this right or if I show up as perfect. Any variation of that thought usually leads to really closed emotions, right? A lot of fear, inadequacy. You can end up being irritated and resentful if anything or anyone gets in your way. Healthy striving, if you have a fun goal that you've set for yourself and you're curious to see if you can do it, leads to much more open feelings and actions and results. This is where we see growth, curiosity. It's knowing that you'll have your own back if you fail. You are allowing for failure without judgment. So you can't tell by the behavior. The action line of these two may look the same. It may be a resident coming 2 hours early to pre-round because they're having fun and curious about it, or because they're afraid that they're going to be unworthy if they make a mistake. The action line of coming 2 hours early tells us nothing unless we get to the thoughts and the feelings behind it. The same is true for you also. Perfectionism sets the bar for success so high and also so vaguely that you don't ever know if you meet it. This is the key to perfectionism. It keeps moving the bar up. So the arrival fallacy of, the idea, I'll feel better when I graduate med school, I'll feel better when I match into the residency that I want, when I get the fellowship that I want, I'll feel like I've made it when I'm a faculty, right? It continues to come up for us. I will finally relax when I've just been promoted to associate professor. I thought this all last year, then I can just relax. We have this idea that I'll feel worthy when, and we know that that continues to just move up, right? We are actually pre-programmed to have this motivator behind us, and our brains just feel the way they feel no matter what. So in medical training, the general model that I see is learners think I'm not enough. They feel inadequate. These are the common actions. They hide, stop learning, don't ask for feedback, disconnect from peers, procrastinate. If they can't get it perfect, might as well not do it. And then avoidance behavior comes in. The result, of course, is that they prove that thought, as results always do, because they are driven from the thought. And at its worst, this is what leads to burnout, right? This is what leads to burnout. It leads to people leaving the profession, and many, many other sort of anxiety, depression, even suicidal ideation. At its core, at its worst, this is how perfectionism shows up. So how can we manage it for our learners and ourselves? The main point is to help your learners clarify their own standards. So having your learners define success for themselves is a really big deal. And I'll often say, they'll say, well, I'll just feel better when I'm a doctor. I'll feel better when I'm a practicing doctor. That's when I'll let myself feel worthy. I'll say, okay, what do you want to get out of this rotation? Or what do you want to get out of your residency or whatever training point you're in? And they'll say, I just want to learn to be a good doctor. That's all I want. I want to learn to be a good doctor. And I say, okay, how will you know when you're a good doctor? And they look at me like I'm nuts. Like, well, I'll just know. I'll know when I'm a good doctor. But they have no actual clear standards. What does that mean to you? Because if you don't know, if you don't have an idea of what you being a good doctor looks like, I promise you will never get there. You will never actually let yourself believe that you are a good doctor if you haven't clearly defined that to signpost it for yourself. So what exactly does that mean to you? We talk about it like 90% of the time, they are already hitting the mark. They're just not letting themselves believe it because they think that letting themselves off the hook or feel an ounce of worthiness will lead to mistakes, and we work on that fallacy. But sometimes there is a skill gap, like, oh, I want to be able to place an art line without having to ask for help. Okay. Instead of making that mean that you're unworthy, do you have a plan to meet that mark? And is it doable in residency? What specifically do you have to do to meet this standard? And then sometimes beliefs here come up that need to be challenged. Like I have a lot of residents that say, well, I guess I'll know it when I get perfect milestone scores and all 100% good feedback from patients and peers and attending. It's like, really? Like, are you sure every single person has to like you in order to be a good doctor? Like, is that even possible? Are you sure you want to keep this belief of success? Are you sure that it will serve you? Or maybe will you never get there if you hang on to this one? So having a learner define what a good doctor means to them will help them so much, and it's specifically showing them, okay, when you meet this mark, you get to feel pride, accomplishment. You get to feel good. And that's where tool 3 really comes in. Practice absorbing praise. This is really hard, both because they don't get very much praise, because medical educators also have a deficiency lens that we look through, and we are constantly looking for where our learners are deficient and where they're doing great. We're like, okay, great, focus on the deficiency. So they don't hear very much praise. But even when they do hear praise, it doesn't make sense in their brains because they're so used to self-criticism that an odd thing happens. Even when negative feedback hurts and it feels bad, it turns out that disagreement with our own story feels even worse to the brain, right? And so if you have a story about yourself, you're walking around thinking, I suck at this, I'm not very good, I'm not ready to be a doctor, and then someone tells you that you're really good at this, that feels so uncomfortable for our brains. That anti-confirmation bias feels really, really bad, that our brains will twist that statement around in sneaky ways to make it fit with their own story. So that's where this idea of they're just being nice, I just got lucky, you know, this wasn't because of me, it was because of somebody else comes in. It's the inner critic twisting the words so that they fit the story and the world makes sense. And it's not that we were wrong, it's just that they're being nice. So we have to rewrite this pathway. And here is one tool to start doing that. I want you to do this with me in real time right now. And this is something that you can easily give to your learners in a team room on rounds. This is a quick exercise. I want you to think back to your last compliment. Pull it to your mind right now. It doesn't have to be at work. It could be at home from your kid or your mom or your dog. And now do that feelings work that I was telling you about. So that compliment is your circumstance. It has triggered a thought about yourself, something along the lines of like, oh yeah, I am kind of awesome. Oh, I really nailed that. And that is triggering a feeling. And I want you to sit with that feeling and get familiar with it. Maybe it's pride. Maybe it's accomplishment. Maybe it's just happiness. Where does it live in your body? Do a little PQRC, because if you're not familiar with the good feelings, you won't recognize them either. And then the second step, and this is really hard for learners, especially learners who have a lot of imposter syndrome, is to think about what you did to create this result. What strength did you use? So this is anti-deflection. This is how did I create this? Specifically, what did I do? What actions? Make sure the attribution is correct. And then this is the key part that's really fun. I tell my learners, guess what? There is very strong evidence out there that says people who walk around with positive feelings, reflections of strength, and remembering their compliments actually show up as better versions of themselves more successful, have better mastery of skills, take on more challenges, and generally do better in their careers. There is data that shows this, and yet here's your inner critic saying, you better not, you'll miss something. But showing them that there's actually data that if you walk around feeling good about your strengths, you are more likely to show up as good in your career, means you can reminisce on this compliment, knowing that it will help you be a better doctor as many times as you want. This does not mean you're getting cocky. It doesn't mean you reminisce out loud, right? I tell them, like, the next time you're on rounds and it's not your patient being presented, you can just be reflecting on this compliment and feeling that joy. First of all, it makes you a better doctor. Second of all, it just feels good. Like, why not? Why would you not do this more in your life? This activity right sizes that negativity bias, right? It sort of tries to drown out that inner critic or help her put on glasses to see things correctly. Actually, yes, there are places I make mistakes, and there are even more places I'm showing up as awesome. I have to tell a story. I just coached a resident last night. She's not from this university. I had prompted her last week. I had thrown something in the chat of our group coaching forum, and I said, challenge this week, think of a time that you are showing up already as awesome and do a thought download on it. And she came to me last night and she said, I took a screenshot of that with my phone. She's a surgery resident on the East Coast. And it made me mad. She said, it made me mad because, I hate it when other people tell me to act confident or act like I know something when I don't. Won't that make me a better doctor? Like, I think you're actually going to make me a better doctor if I'm allowed to feel that I'm amazing. My prompt was, think of one area that you're amazing already. And it made her mad. And we coached for a long time, and it was a very tearful revelation of this fact that she thought she had to feel like total shit in order to do well in her profession, and maybe that was wrong. But it's like shocking to me still every time this comes up that residents, and probably us too, also have this idea that we are not allowed to feel good about ourselves if we want to show up as good doctors. Okay, so as an attending in a team room, acknowledging efforts and process over outcomes will help point out those strengths to our learners, naming them for them. If we got as specific about positive feedback as we did about negative feedback, SMART, positive feedback, specific, measurable, do this again. I saw you in flow here. If we got as curious about their strengths just for like a day as we did about their deficiencies, imagine how much easier this would be. And then I have a zero tolerance policy for self-deprecation. If I hear it, I will call it out, and we do everything we can to banish it. It's not allowed, right? Modeling this is even harder. Okay, thanks for hanging with me, Grand Rounds audience. Here's what we did. We identified the cause. It's the inner critic. The effects are sad, burnout, anxiety, depression. And then I taught you 3 tools to mitigate it. Most important one being the model. If you want to know more about the coaching program and what I'm doing, that's our website there, where we dive into imposter syndrome and more kind of on a deeper level. Does anyone have any questions? If not a lot, please email me if you do have questions. Email me a thought download or a model. I've had people do that after presentations before. It's really fun if you have questions about what goes in what line. TBC, yes. So the coaching program right now, Adrienne Mann and I run Better Together Physician Coaching. It is for residents. We are currently coaching a cohort of over 1,000 residents in 30 institutions across the country. We're doing an RCT of that program right now. You're going to open it up to that. Those are residents that identify as women. We're going to open it up and do a CU pilot of residents that identify as men in the winter. And we have coached faculty, mostly junior faculty, in different departments across the campus in individual coaching. It turns out it's much harder to sell faculty on a group coaching model. And we are open, our ideal goal is to have this umbrella program of Better Together that can reach out to various faculty groups in medicine and surgery across the country, and eventually to different career stages also. So medical students, APPs, nurses, we'd ideally like to recruit coaches that identify as those. And so we'd have APP coaches, which there are plenty. But right now, as we're growing, the coaching program is just for residents and fellows. Stay tuned.